This presentation is an introductory look into the alpha-1 antitrypsin deficiency, which will hereby be referred to as AATD by Paula Carter. In this presentation, we are going to look at what AATD is, what are the predisposition factors of AATD, what are risk factors associated, and we're going to look both at environmental and lifestyle factors. What is the role of the nurse, health prevention and risk reduction, and cultural aspects. What is AATD? It is a protein that is produced by the liver. It protects lungs and major organs from inflammation caused by irritants and inhalants. A deficiency in AATD can lead to liver or lung damage at any age. The deficiency causes low levels in the bloodstream, and also it causes an abnormally shaped protein. When these proteins are abnormally shaped, they get stuck in the liver and are not able to travel through the bloodstream to protect the vital organs. Low levels or deficiency can lead to permanent liver and lung disease. This slide illustrates the Z allele, the abnormally shaped protein, which in its shape inhibits the escape through the membranes of the liver, causing an accumulation in that organ, which then causes the destruction of the liver. Genetic predispositions to AATD. It is a genetic inherited condition. A deficiency or abnormal gene must be present in both the maternal and the paternal genes of the parent. Normal AATD alleles are known as M, while abnormal are known as S and Z. M alleles are of normal size, shape, and quantity, hence normal functioning. S and Z alleles are both abnormal, the Z abnormalities being much more harmful. Inheritance of an S and a Z allele can be fully functionally deficient. An inheritance of an S and a Z allele, meaning an S from the maternal and a Z from the paternal, can also be functionally deficient. The inheritance of two Z alleles is what leads to the inadequate production and the abnormal shape of the protein, therefore causing it to get stuck in the liver. The inadequate production leads to an insufficient amount of protective proteins that are important to vital organs. The abnormal shape leads to an overaccumulation in the liver, which causes little or no disbursement to the bloodstream, and therefore a harmful abundance in the liver. This is an autosomal recessive codominant homozygosity of the protease inhibitor Z allele and occurs on chromosome 14. Risk factors, we're going to look at environmental. Many professions can contribute greatly to an already deficient population, according to Nelson. These professions are mainly painters, welders, chemical plant workers, any types of drivers that would be inhaling any toxic fumes, being cab, bus, or train drivers. Any farmers, either agricultural or organic, miners, textile workers, and mill workers. Lifestyle choices that contribute greatly to an already compromised deficiency. The one and only that I could find listed is smoking. Smoking, according to Stoller, is the major risk factor for accelerating COPD and emphysema in AATD patients. Health prevention for those who are affected by acquiring 2Z alleles. First and foremost, do not smoke. If you do, seek smoking cessation assistance. Wear protective masks with any and all exposure to any chemical or dust inhalants. Other options you can do is explore benefits of augmentation therapy, and this is disease-modifying progression that Marcinek wrote a quite extensive article on. And then teaching awareness of clinical presentations of AATD, which are mainly shortness of breath with any mild exertion, wheezing, repeated respiratory infections, and a rapid heartbeat upon standing. And these symptoms can begin at an early age and can be in their worst periods as early as your 20s. The role of the nurse is to assess and monitor respiratory function, assess and monitor O2 saturation levels due to hypoxia being a major factor of respiratory failure, assess and monitor liver function tests and enzymes, administer long-acting inhaled beta-adrenergic and anticholinergic for bronchodilation as ordered by the physician in times of exacerbation. Educate the patient regarding available genetic testing to detect risk and predisposition. Educate importance of pulmonary rehabilitation to decrease hypoxia. Again, hypoxia being the leading cause of respiratory failure and respiratory distress. Educate regarding augmentation therapy to modify the disease process. And Chapman also wrote a quite extensive article regarding this study into augmentation therapy. It's quite interesting. We also want to educate regarding utilizing protective equipment during any dust or chemical exposure. Educate and provide support for smoking cessation. Encourage the patient to utilize medical resources whenever an exacerbation occurs to decrease hypoxic episodes. Provide education and administration of immunizations for influenza and pneumonia. Both of those are leading causes also of respiratory disease. Educate regarding signs and symptoms of liver cirrhosis, any yellowing in the skin, whites of the eyes. Replace enzymes as ordered by your physician, and provide support. That's one of the primary cares of the patient who is AATD affected. There are some barriers to the diagnosis of AATD. One of the primary barriers is the under-recognition. A lot of patients who perhaps may have AATD, when they come in ill, a lot of times the diagnosis is based on exacerbative episodes wherein the shortness of breath or hypoxic episode, it's not really looked at into the deficiency, which is a simple blood test to evaluate levels. Variable expression existing among individuals with identical deficiency genotypes, even accounting for smoking. There are false negatives. If it is in an acute phase reactant but severely deficient, they could have a very low level. So keeping an eye on those labs over a period of time would be very important. And deferral of genetic testing. There are a lot of factors that inhibit or prevent pursuance of genetic testing. The cultural aspects associated with AATD. It's most common in Northern European ancestry. It affects nearly an estimated 1 in 4,700. And the severity varies greatly even in those among the same genetic line due to associated risk factors, both being either environmental or lifestyle associated. Genetic testing in Northern Americans has not really any ethical barriers. However, the lack of understanding is the biggest barrier regarding the necessity of genetic testing. The cost of genetic testing is also a primary downfall. Most insurance companies won't pay for genetic testing. Genetic testing in some cases may be used to discriminate. A good example of that, which there was a complete article from Larati on, is that if you are in for physical and blood work is done, and that is a test that is incurred, this deficiency would deter being hired in perhaps a high-paying factory job or a mill where, that may be the primary income of that community. Nursing discussion with the patient to assess the family history of disease process along with the individual risk assessment to encourage prevention of disease progression. Recognition of cultural associated risks and therapies available with genetic counselors for offspring. Future research is necessary to provide further understanding and quality trials. Encouraging education in genetic foundations and organizations will increase the hope of the patient who is affected by AATD. The next 2 pages are references. Thank you for listening.